Hi, g'day. This is Elisha Road. I'm a medical officer in urology at Groote Hospital in Cape Town. Today we're just going to chat quickly about sexually transmitted infections. Try and keep this talk rather short, about 20 minutes. We just want to get a brief overview of sexually transmitted infections and just sort of guide and provide a foundation for further reading. So in my talk, we're going to look quickly at the epidemiology of sexually transmitted infections. We'll jump into the risk factors. We'll look at how one can approach diagnosing sexually transmitted infections before moving on to some of the syndromic entities such as male urethritis syndrome, scrotal swelling, genital ulcer syndrome, and then we'll have some concluding remarks. So regarding the epidemiology, we know that sexually transmitted infections are infections that are transmitted either by sexual intercourse or by orogenital contact or non-sexual ways, common use of intravenous drug materials, as well as by congenital transmission. Globally, about 1 million people are infected with an STI every day, and about 374 million people are carrying and infected with one of the 4 potentially curable STIs every year, a large proportion of which are asymptomatic. Here at home in South Africa, we find ourselves not only at the epicenter of the HIV pandemic, but many sources quote us as having the highest burden of sexually transmitted infections. And the substance of the sexually transmitted infection issue is largely to do with the public health and far-reaching effects of sexually transmitted infections. Every year, about 350,000 births are adversely affected by syphilis infection. We know that there are more than 311,000 deaths annually due to HPV-related cervical cancer. Infertility in Africa can be largely attributed to sexually transmitted infections, with more than 85% of cases having a sexually transmitted infection as an etiology. And then sexually transmitted infections gives rise to a 3-fold increase in contracting HIV. When one looks at the risk factors, it goes without saying: risky sex partners, unprotected sex, a higher number of lifetime sex partners, alcohol and drugs. And then also interestingly, there is a disproportionate increase in risk for men who have sex with men, with 75% of them being, or they're having a 75% greater risk for contracting a sexually transmitted infection. How one decides to approach sexually transmitted infections is dependent on a few factors. And the first thing is that there are about 30 pathogens that we know that can cause sexually transmitted infections. And of these 30 pathogens, they tend to have overlapping symptomatology, meaning that, there are quite a number that can cause male urethritis syndrome, penile discharge, ulcers, painful lymphadenopathy. And added to this problem is the fact that one can also be infected at multiple sites. For example, a woman can be infected in both the vagina and the cervix, and this makes it particularly challenging. So from this, there are 3 ways in which one can approach sexually transmitted infections. The first one is that one can be dependent on a clinician to look at the clinical features and diagnose it and treat accordingly. The issue with that is that the evidence has shown that it's a bit of a 50-50 or flip of a dice, in that it often leads to misdiagnosis, often leads to complications, and these patients tend to leave or continue having ongoing infection. One could also just test everything, send off tests for all of the entities, wait for that result, and then treat it accordingly. The advantage would obviously be precision medicine or antibiotic stewardship. The disadvantage is that a lot of these tests are intensive in terms of personnel, equipment, and time, and cost more. And then the final way in which one could approach it is we could group diseases according to the symptoms that they cause, and then we could give blanket cover in terms of antibiotics. The disadvantage of this would be the cost, number one. Secondly, antibiotics, especially general or broad spectrum antibiotics, result in flora changes, which can have adverse effects on the patient's health. And then also the emergence of resistance poses a significant side effect or complication of a syndromic approach. But in South Africa, since 1994, we've been making use of the syndromic approach to the treatment of STIs. And this was propagated by the WHO in the 1990s for developing countries, given the hurdles that we have in terms of cost and personnel. We also have patients that are largely of a low socioeconomic standing, which makes them prone to follow-up. So therefore, identifying them, diagnosing them, sending them home, and then having them come back for antibiotics poses a bit of a gap in healthcare and makes these patients susceptible to being lost to follow-up. The other thing is that the syndromic approach neatly fits into a few of our other public health programs, and that would be our primary care program, our maternal and child health, as well as our family planning clinics. So syndromic approach in South Africa really is what we go for, and it works well for us. But it's important to remember that there is a role for the etiological approach in certain settings, such as patients who are failing first-line management according to the syndromic approach, as well as high-risk sexual behavior groups. These would be men who have sex with men or sex workers. It's important to remember that there are other approaches that we can use to identify and treat. So jumping into the syndromes, the male urethritis syndrome, we commonly divide it into gonorrheal urethritis and non-gonorrheal urethritis. Neisseria gonorrhea is a gram-negative diplococcus. It's got a 3 to 14-day incubation period. Most men tend to be symptomatic, and therefore they seek treatment earlier. They develop symptoms of urethritis, epididymitis, proctitis, and prostatitis. They therefore get treatment earlier and they get cleared of this infection. An issue comes with females who are frequently asymptomatic carriers until they develop ascending tract infections such as pelvic inflammatory disease, and we know about its sequelae that result in chronic pelvic pain, infertility, as well as a predisposition to ectopic pregnancies. The recommended treatment for male urethritis syndrome is dual therapy due to its frequent concomitant infection with chlamydia. But as of 2007, there has been emerging patterns of antimicrobial resistance. Since 2007, our fluoroquinolones have become less sensitive in the setting of gonococcal infections. And as of 2012, we see a rise in the extended spectrum gonococcal infections, which have rendered them less susceptible to third-generation cephalosporins such as cefixime and ceftriaxone. Current recommended treatment would be for uncomplicated ceftriaxone and azithromycin, or a tetracycline such as doxycycline. Second-line treatments, spectinomycin or gentamicin and azithromycin. In terms of non-gonococcal infections, the vast majority are caused by Chlamydia trachomatis, and then there's less so caused by Mycoplasma genitalium or Trichomonas vaginalis, adenoviruses, and herpes simplex virus. Chlamydia is the most common bacterial sexually transmitted infection, and it's prevalent in men above 25 years of age. It commonly causes epididymitis or Reiter syndrome, which is often remembered by the can't see, can't pee, and can't climb a tree, relating to the conjunctivitis and arthralgia along with the epididymitis that's caused in men. Similar to gonococcal, women tend to be asymptomatic carriers. They develop ascending tract infection in the form of pelvic inflammatory disease and then consequently go on to develop its complications. The initial treatment is co-infection management similar to gonococcal urethritis using azithromycin here. Alternatively, one could use erythromycin, the macrolide, or a tetracycline, and if there's a suspicion of a trichomonal vaginalis infection, you can add metronidazole. The issue of recurrent or persistent urethritis often occurs in patients that have either not been compliant to treatment or have been re-exposed to the bug, and the recommendation is that one should then retreat these patients. But if you've given them a tetracycline, one should be aware of the emerging resistance to tetracyclines, and for that you can alternatively give them metronidazole as a stacked 2-gram dose along with azithromycin, or a fluoroquinolone such as ciprofloxacin or moxifloxacin. Scrotal swelling syndrome. So this comes in the form of epididymitis, acute inflammation of the epididymis, and if it's for less than 6 weeks, we term that acute. For more than 6 weeks, we term that chronic, and that tends to be commonly caused by TB. When there's concomitant infection of the testes and inflammation thereof, we call that epididymoorchitis. Now, they've got an interesting pattern of epidemiology. In men that are sexually active and younger than 35, we see our common urethritis organisms in the form of Neisseria gonorrhea and Chlamydia trachomatis. But for men who have sex with men, we see more enteric bacteria such as E. coli, Pseudomonas, For men over the age of 35, these patients tend to have bladder outlet obstruction due to, amongst other things, benign prostatic hyperplasia. And for that reason, they also tend to get enteric bugs. Whilst our patients with HIV, specifically those that are immune suppressed with CD4s of less than 350, we tend to see our atypical organisms in the form of CMV virus, salmonella, corine bacterium, mycoplasma, and fungi. The diagnostic principles in managing scrotal swelling syndrome is to firstly exclude torsion. We can do Gram stains on urethral secretions, or we could do dipsticks and look at the leukocyte esterase tests. We could also do urine microscopy looking for white blood cells. The recommended treatment in men under the age of 35 with the typical organisms of of male urethritis syndromes, ceftriaxone plus azithromycin, or ceftriaxone plus a tetracycline. In men over the age of 35 years, or men having sex with men, we give them ceftriaxone, but we also cover for enteric bacteria using a fluoroquinolone such as levofloxacin. Genital ulcer syndrome is caused by a myriad of organisms ranging from syphilis to herpes to chancroid to granuloma inguinale, lymphogranuloma venereum, as well as a human papillomavirus. Syphilis, probably best known by most clinicians, caused by a spirochete known as Treponema pallidum. It's transmitted by sexual contact, and these usually occur at sites of microabrasions, and at those sites we see a rapid replication of the microorganism. We can divide syphilis into primary infection, secondary, latent, and tertiary. And primary represents the area where that infection has initially occurred, and at that site men and women develop painless ulcers. These are termed chancres. In men it often occurs at the glans or at the coronal sulcus or perineum. In women often at the labia majora or the perineum. And these spontaneously will heal by 2 months. For those patients that are not treated and progress to secondary, they'll develop a systemic infection that results in a bacteremia, and they undergo the spectrum of changes that ranges from a maculopapular rash to ulceration to these wart-like lesions that are termed condylomata lata. They can also develop vasculitic sequelae such as a aortitis from syphilis. Then, if they manage to not be treated and soldier on, they develop latent infection. And latent infection, the hallmark of which is that your patients are asymptomatic, but they are now seropositive. And either they are seropositive with a previously demonstrated negative test in the last year, in which that is termed early latency, or they are seropositive and they've never before had a negative test, or we do not know when last that negative test was, and that would be arbitrarily termed late. 35% of patients that enter latency will then go on to have tertiary syphilis, and those manifestations include neurosyphilis, cardiovascular syphilis, or gummatous syphilis. From a neurosyphilis point of view, they can develop damage to their dorsal columns, and that syndrome is termed Tabes dorsalis. They can also develop severe neurocognitive sequelae, which is termed loosely termed, or was eponymously termed the general paralysis of the insane. They can also develop a cardiovascular complication such as an aortitis, and otherwise they can also develop soft tissue lesions, destructive soft tissue lesions, which are termed gamma. And these lesions are essentially granulomas that undergo coagulative necrosis at the center, and that differs from tuberculosis, where they also have granulomas, but there they undergo caseous necrosis at the center. One could test for syphilis in a few ways. Number one, we know that it doesn't grow in vitro culture, so we can use microscopy to try and identify the bug, and that's got a 97% sensitivity. The downside of that is that it is labor intensive and expensive. The common ways in which we diagnose this out here in South Africa is making use of either non-treponemal or treponemal tests. And our non-treponemal tests utilize the detection of antibodies against phospholipids. And those would be your venereal disease research laboratory test, your rapid plasma reagent, or your TRUST. And those, because they detect antiphospholipids, they can also be triggered or falsely raised by a number of conditions, most importantly your connective tissue diseases. In terms of antibodies, these detect antibodies against syphilis, and they're dependent on using blood that's got the syphilis antigen in, and it causes in one or other way an agglutination on the test with the patient's blood, demonstrating that there's an antigen antibody reaction, and that demonstrates antibodies against syphilis. The downside of that obviously is that we do not know if this patient was previously treated. Another advantage of our non-treponemal tests would be the fact that we can monitor a response to treatment based on the titer. So HIV and syphilis has an interesting reaction. HIV results in a rapid progression of syphilis, and specifically a rapid progression of syphilis to neurosyphilis, while syphilis also results in a rapid progression of HIV, and syphilis also can result in more than, it will result in more than 25% of patients contracting HIV as well. When it comes to the treatment of syphilis, the mainstay is penicillin or benzathine penicillin, and the only thing that differs is your duration of treatment. With those having primary, we go a single dose. If they're latent syphilis, we do once weekly for 3 weeks, whilst tertiary syphilis, we utilize intravenous penicillin for a day, for an approximate duration of about 10 to 14 days. Treatment failure. So in patients that have persisting or recurrent signs and symptoms, or those patients that show a fourfold increase or do not drop their titer by fourfold, one has to consider that your treatment has failed. And there's a few things that one has to consider when that happens. Number one is you need to retest them for HIV because they might be immune suppressed. Number two is that we need to evaluate them for neurosyphilis, in which case a lumbar puncture or CSF testing may be indicated. And then one should probably consider retreating this population to see if there's a response. Herpes, so human or herpes simplex virus, one of the traditionally easy remembered viral infections. Herpes simplex 1 is conventionally remembered as the one that causes oral infections, but it's important to remember that about 50% of first episode genital herpes simplex or genital ulcers is caused by herpes simplex virus 1. Herpes simplex virus 2 also causes genital herpes. You can have asymptomatic carriers, and we know that women have an increased susceptibility to being infected with HSV2. Just a brief summary of the pathophysiology of herpes, and that's that we get infected at the level of the epidermis or dermis. The virus travels along the nerve to the nerve root, where it will become latent and go into dormancy, and at times of reactivation, which can be stimulated by heat, stress, infection, trauma, the virus then travels again back to the dermis and produces the stereotypical lesions. So the lesions of herpes simplex is an erythematous papule that goes on to become vesicles or water-filled small blisters on the external genitalia. They also result in pain, burning, itching, and some patients will have dysuria or burning on passing urine. Primary genital HSV1 can't be distinguished from HSV2, and there's a clinical significance to that. And that is that we know that HSV2 has got a bit of prognostic impact on HIV, as those patients are more prone or more likely to be severely immune suppressed. And there's also a good argument that patients infected with HSV2 should probably be on chronic suppressive treatment with acyclovir. So there's two ways in which one can demonstrate a difference between or detect whether it's HSV1 or HSV2. Number one is if there's a lesion, one can swab that and send that for testing in the form of viral culture, antigen detection, or polymerase chain reaction. If there's no lesion, one can test for immunoglobulins in the blood. Treatment of herpes. The virus is never eradicated, so our treatment is merely aimed at suppressing or shortening the duration of the symptomatology. We can treat based on clinical effects. We can use acyclovir, valacyclovir, or famiciclovir, 7 to 10 days duration, and one can extend that, and then intravenous use is recommended if there are neurological complications or patients can't take oral medications or there's widespread disease. Chancroid, so Haemophilus ducreyi, causes anogenital ulceration associated with lymphadenitis, and those eventually form pus, those lymph nodes, and that's termed a bubo. And bubos will result after the progression of papules to ulcers. There's no FDA approved test for chancroid, but one can make a probable diagnosis of chancroid based on the fact that the patient has one or more ulcers. You've excluded syphilis using one of the tests. Those ulcers have associated lymph nodes that are typical for chancroid, and if you have run any other tests on the ulcer exudate, you've also excluded herpes simplex using those tests. So the treatment for chancroid is ceftriaxone or azithromycin or the macrolides, or you can use a fluoroquinolone. Granuloma inguinale. Despite the name granuloma inguinale, only about 10% actually have inguinal lymph node involvement. It's caused by a group of Klebsiella granulomatis, common in South Africa, Papua New Guinea, India, and Brazil. It's got quite a long incubation period, and they present with painless, slowly destructive, and progressive ulcers on the genitalia and perineum. The hallmark of the clinical characteristics is that they've got these beefy red ulcers, and that's because they're quite vasculitic, these ulcers. They also get extragenital manifestations, and that can be in the form of teeth loss due to bony destruction, which happens in the mandible. It can also happen in the pelvic bones. When one puts it under microscopy, you can see this conglomerate of dense cells, intracytoplasmic bodies, which are termed Donovan bodies. Lymphogranuloma venereum, it's a subspecies of chlamydia that causes it, the serovariants L1, L2, or L3. They've got an incubation period of 3 to 30 days. The first stage of lymphogranuloma venereum is a transient ulcer, which is often missed, but the most common presentation are these tender inguinal or femoral lymph nodes, which are usually unilateral. You can test either the ulcer or an aspirate of the lymph node and send that for nucleic acid amplification tests or direct immunofluorescence or cultures. The treatment for both granuloma inguinale as well as lymphogranuloma venereum is your tetracycline, doxycycline, 100 milligrams BD for at least 3 weeks. We wrap up with just a few mention on the humopapillomavirus. We know that there are more than 100 of these that exist. More than 40 can infect genitalia. Those most commonly associated with anogenital warts is your subtype 6 and 11, while 16 and 18 are associated with cervical and anogenital carcinoma. An interesting fact is about 50% of sexually active people will become infected at least once in their lifetime with HPV. In terms of its pathophysiology, it infects the dermis, the cells in the dermal layer, the cells in the basal layer of the stratified squamous epithelium, and it will then migrate upwards and proliferate once it reaches the epithelium. From a urological point of view, there are a few other presentations. They can also present with urethral warts, and these patients could have occlusive warts, which could result in urinary obstruction. They can have dysuria, they can have hematuria from these lesions. They can also get Bowenoid papulosis, which are these brown verrucous type lesions on the penis. They are low-grade carcinoma in situ, and they've got a low percentage that will progress to a full-blown malignancy, and that's 2 to 3%. They can also have these large verrucous exophytic lesions termed Buschke-Loewenstein tumors. That's caused by 6 and 11, and they're also a low-grade verrucous carcinoma. The challenge clinically is deciding which of these lesions need to be biopsied, and one should probably biopsy any wart that is 1 as an uncertain diagnosis attached to it. You're not completely, and that probably goes hand in hand with warts that do not have a typical appearance. So they're either pigmented or indurated or fixed. In your immunocompromised patients, there can be an argument made for it. If there's no response to your treatment modalities, or if there's persistent ulceration or bleeding, these all probably merit a biopsy. Treatments for human papillomavirus, these do not eradicate infection, but rather eradicate infected cells, and your treatment modality is guided by the size, the number, the location, or the patient preference. Our regimens can be divided into those provided by the patient and those are applied by the provider. Right, a few of them are listed here. The essence of it is that all of these modalities either arrest mitosis or induce apoptosis of these infected cells. From a surgical point of view, it's important to remember we don't like using Bovie cautery because we aerosolize the virus and can in that way spread infection. Other surgical therapy that we can use is direct excision with scissors, tangential shave excision, curettage, or carbon dioxide laser. A few words on the vaccine. So the initial vaccines, Gardasil and Cervarix. Gardasil protected against subtype 6, 11, 16, and 18, which meant that they protected both against the transmission of anogenital warts as well as some of those that cause HPV-related cervical CA. So there was about a 70% protection. Cervarix, on the other hand, was only 16 and 18, which meant that it only protected against those causing cervical CA. So it had the same 70% protection. One now gets the Gardasil 9, which goes on to extend its spectrum to 31, 33, 45, 52, and 58. These are also implicated in oncogenesis. So the protection has now increased from 70% to 90%. Currently, there's a strong drive in South Africa. We understand from the aforementioned point that if 50% of people engaging in sexual activity will develop HPV, there's strong public health utility in providing a vaccine to both boys and girls of consenting age or those engaging in sexual activity. So in summary, there's far-reaching healthcare effects relating to sexually transmitted infections globally as well as in South Africa. South Africa, we've got a heavy burden, and for that reason it's important that we treat these infections. Utilizing a syndromic approach, it's an easy way to deal with it, but there are situations where a more tailored approach would help, such as in those failing treatment, such as in those that are prone to atypical infections. I was always taught STIs aren't in packs, and with that said, it's important to test these patients for HIV. And with the growing awareness and growing availability of HPV vaccines, it's important to actively encourage our youth to get these vaccines. Right. Thank you very much for having a listen. These are my details. If you've got any questions, you're welcome to email me or drop a message in the comments. Thank you.